It's going to be a very interesting evening, a very informative. I'm going to be the moderator for the evening. And before we get started, can you please kindly mute yourself? And we will have time reserved at the end for questions. So please type in your questions in the chat box, or you can text me or Emily personally, and we can then include your questions. For those of you who are not CANIBD nurses online, CANIBD is a community of practice of nurses across Canada in the field of IBD. The vision is to ensure people of all ages living with IBD in Canada receive high quality clinical nursing care within a multidisciplinary team. The community of practice of we are a community practice of Canadian Association of Gastroenterology and Nurses, which is CSGNA, and we are supported by Crohn's Colitis Canada. I also would like to thank Pfizer, especially Caroline, who has been working with me, and Jennifer Stratton in the past few weeks to get this presentation and the speaker this evening. And now it gives me a great pleasure to introduce Dr. Michael Auerbach. He's a clinical professor of medicine. He's a hematologist and an oncologist at Auerbach Hematology and Oncology Associate Incorporated in Baltimore, Maryland, and he's a clinical professor of medicine at Georgetown University School of Medicine in Washington, D.C. Dr. Auerbach earned his medical degree in New York Medical College in Valhalla, New York. He completed his internship and residency in internal medicine at the Cleveland Clinic Foundation in Ohio. Subsequently, he completed his fellowship training in hematology and oncology in Columbia Presbyterian Medical Center and Harlem Hospital Center in New York, where he went to do research fellowship in thrombosis and hemostasis at Columbia. He is a board certified in internal medicine and in subspecialties of hematology and medical oncology. Dr. Auerbach has co-authored multiple journal articles, book chapters, and meeting abstracts, most recently focusing on intravenous iron supplementation in pregnancy and in patients with restless leg syndrome. He is an author of the treatment of iron deficiency anemia in adults, anemia in pregnancy, and diagnosis and cause of iron deficiency anemia for Up to Date. He is a member of numerous professional organizations and a fellow college of physicians and an honorary emeritus member of the American Society of Hematology. He currently serves on the scientific board of Network for Advancement of Transfusion and Alternatives, advises the Society of Advancement of Blood Management, and is on the editorial board of American Journal of Hematology. I've still got more to say, but I would like to welcome Dr. Auerbach to present on anemia in IBD. I first met Dr. Auerbach in February at the Digestive Disease Week, and I was very impressed with his presentation. And I thought the nurses, the CANIBD nurses would really enjoy the presentation as well. Welcome, Dr. Auerbach.
Thank you.
Okay, I'll let Dr. Auerbach share his slides.
No, okie doke. Okay, are we good?
Yeah.
Okay, how are you? My name's Michael Auerbach, and I'm still in private practice in Baltimore, but I'm on the faculty of Georgetown University. Some of what I'm going to say today is going to be hard for you to take because it's really going to criticize the current standard that I think is long in need of revision, especially in your patients. overwhelming majority of whom are made miserable by oral iron, which still remains frontline care, and show you why it's even more difficult as we get later into the talk. I have my page down button doesn't work. Any idea why?
It just click.
Click the.
Dr. Auerbach, try clicking on your slide with your
All
mouse.
right, I got it. There's an arrow there. I've got it. Okay. I received data management funding from AMAG Pharmaceuticals. So what we're going to do today is talk about the need for oral or IV iron for iron deficient patients. I want you to become familiar with the formulations. In Canada, you have two.
Welcome to the prescription dictation service.
Usha, can you, I hear something in the background about a dictation service. Okay. We're going to talk about the formulations that are available to you. But most importantly today, you all learned IV iron was dangerous, and I'm going to show you why it's not. Make sure that you become able to differentiate the minor infusion reaction, which occurs about 1% of the time, with severe hypersensitivity, which occurs less than 1.25 of a million infusions, and that's less than penicillin, in case you're interested. And then we're going to review evidence-based treatment approaches with iron supplementations, not only in IBD, but we're going to go into obstetrics and gynecology, because I assume that most of you are women, and what I'm going to show you about pregnancy will make your hair stand up. So let's begin. It's hard to change something that's been around for so many hundreds of years. Sydenham first used iron in 1687 by putting iron filings in cold wine to treat what was called the green sickness that was described by Lang in the 1500s. Then in the 1800s, Blaud renamed it chlorosis, and he was the first to use ferrous sulfate to benefit iron deficiency. By the time the American Civil War came along, iron was being used to treat war wounds, and today, there are almost 3 billion people in the world with it. It's the most common micronutrient deficiency. It's estimated to affect greater than 35% of the world's population and 50% of pregnant women. It's 100 times more prevalent than all of cancer combined. And here we are, almost 300 years, greater than 300 years later, using the often ineffective, usually poorly tolerated oral iron as our frontline therapy for the commonest malady on earth. The symptoms are both specific and vague. Everybody knows about fatigue, but fatigue's a hard one to put your hand on. You can get fatigue for a million different reasons. But a craving for ice or other forms of pica. I've seen paper, clay, dirt, toothpicks, rubber bands, Argo and Niagara starch, baking soda, fabric softener sheets, uncooked pasta, uncooked rice, cornstarch, sand. True in my practice. But ice, that's the commonest. If someone's chewing ice, they're iron deficient. Still have to have iron studies, and the insurances won't let you give it. But if you're craving ice, you're iron deficient. Restless leg syndrome. I'll bet a few of you in this audience have it. It's miserable. Keeps you up at night. Got to get up and walk around. Interferes with your sleep, exercise tolerance. Awful symptom. If you have restless leg syndrome, there's a 90% chance you're iron deficient. If you're iron deficient, there's a 40% chance you have restless leg syndrome. If you have restless leg syndrome and you're iron deficient, there's a 90% chance you won't be. the evening that you get intravenous iron. You will be with oral iron. Brittle integument you know about, but I think I have a picture that's worth looking at here. Nope, sorry. Get horizontal lines and fingernails. Can they see me or not? Horizontal lines that run across the fingernails. They're called koilonychia. And the tongue loses its papillation. I don't remember if those slides are in this deck, but if they are, they're cool. So let's talk about indications. Up-to-date is the most viewed medical publication on earth, and everything we say has to be evidence-based. So when I say something to you that's not in up-to-date, and because it's my opinion, I'll let you know. Up-to-date is evidence-based. So it says this in up-to-date. Oral iron is front line for mild uncomplicated iron deficiency without active bleeding, because there's really no credible expectation that you're going to keep up with blood loss. It's not going to happen. And I'll show you slides later on which really support that conclusion. In the first trimester of pregnancy, somebody needs to mute, please. In the first trimester of pregnancy, where there's no safety data, oral iron is indicated. And I'll show you why 1 tablet every other day is the way to take it. And in the second trimester of pregnancy, if the hemoglobin's greater than 10, there's still going to be some benefit from oral iron. Not much. Remember, the patient has to take it. But IV iron, for anybody who's intolerant of or unresponsive to oral iron, in the second trimester of pregnancy, if it's less than 10, at all times in the third, because it does not get to the baby, after bariatric surgery, where it not only doesn't work, makes patients worse, with abnormal uterine bleeding, because there's no credible expectation you're going to keep up with losses. In inflammatory bowel disease, where it not only doesn't work, it makes the intestinal epithelium, it actually aggravates the IBD, which is pathological evidence of that, independent of anemia, and causes an incommodious growth of the intestinal bacteria, negatively altering the microbiome. In my opinion, it does not say this in up-to-date. Giving an IBD patient oral iron is cruel. That's the term I use. If it upsets you, mention it when you have questions. Angiodysplasia, where you have no chance of keeping up with the losses, and when there's a coexisting inflammatory condition where the elevation of hepcidin, which we'll go over briefly, blocks its utilization. So these are the indications that we put in the up-to-date section. I want to just fly through this, okay? Your new iron is all the way on the right, which now has a new, unbelievable, a new generic name. As if this business is not hard enough, we had to change generic names. And it's called iron ferric dirissomaltose now. So, too bad. That's what it is. It's not my fault. World Health Organization and FDA mandated the change. But take a look at the left, ferric hydroxide. It was so toxic that people wrote IV intravenous parenteral iron should never be given. And it almost never was. But in 1954, iron dextran came along, and a large dose could be given in a short period of time, but it was still associated with hypersensitivity reactions, which we'll talk about. And as a result, it was considered dangerous and rarely used. Let's fly forward quickly. Erythropoietin came out in 1989, which created a need for iron because EPO doesn't work without iron, even if the patient is iron replete. And Infed, or low molecular weight iron dextran, which, believe it or not, is made by the same company who makes monoferric or ferric dirissomaltose, was used. And if you talk to dialysis doctors back then, they were thrilled with it. There was virtually no toxicity. Unfortunately, In 1996, this dreadful compound, high molecular weight iron dextran or dexferrin, came out with the highest incidence of serious adverse events ever seen with any formulation, and it poisoned the horizon for iron safety, which persists today. You all learned in nursing school, IV iron's dangerous. Let me tell you, you learned wrong. It's not. I'm going to show you why. I'm going to show you how to avoid danger. Anytime you give anything IV, there's a risk of serious adverse event. But in terms of frequency of serious adverse events with IV iron, they are vanishingly rare. 3 compounds came out that allow total dose replacement in 15 minutes in addition to low molecular weight iron dextran, which can do it in an hour. Ferraheme in the United States, you don't have it, you used to, but they came out with the extremely dumb recommendation to give 510 milligrams in 17 seconds. Minor infusion reactions, which I'm going to show you, were frequent, and the drug got a terrible smell, a black box warning, and it was removed from Canada and Europe. It wasn't until just a couple of years ago when they did a 2,000 patient study, a 2,000 patient study of double-blind ferraheme to ferric carboxymaltose or Injectafer, which I don't think you have in Canada, and showed equivalent safety, and the FDA gave it a broad label, but it's not available in Canada. And now you have monoferric. Monoferric was approved in the United States as the first intravenous iron approved for a total dose infusion, where the total dose can be given in one sitting. Think of it, a year of taking iron pills with all the misery that is completely replaced by 15 minutes of intravenous iron. I mean, somewhere common sense has to prevail. These are the formulations. In the United States, there is a black box warning for low molecular weight iron dextran and ferumoxytol, but not for any of the others. And I don't think you have them in Canada, so it does not apply to you. These are the approvals. Now here, iron dextran, which you don't have, is approved for 100 milligrams over 2 minutes. That's just a plain, stupid way to give it. It's the FDA approval. It could not be more ill-considered. It requires 10 visits, 10 IVs, 10 chances for an extravasation to do what you can do by giving a gram in an hour once. We've published this over and over again. Thousands of patients have been published, and I've given approximately 15,000 doses of a gram in an hour, and it's absolutely the equivalent in safety to 100 milligrams times 10. Same true with ferumoxytol, but these are not in Canada, so let's not dwell on it. Ferric carboxymaltose is approved in the United States, but it only comes as a 750 milligram vial, and I don't think more than a gram makes any difference because we really can't utilize it, and I'll show you that in the next slide. And now your new drug, ferric dirisommaltose, which you first learned as iron isomaltoside, and you can give up to 2 grams, but I wouldn't give more than a gram of this because I don't think there's evidence that more than a gram is better. Perhaps we'll get that data in the future. So very briefly, the liver makes hepcidin. Hepcidin's the iron regulatory protein. When iron is absorbed on the gut side, it comes in by enzymatically by something called divalent metal transport protein, brings it into the cell. It's got to get across the cell in order to get into the circulation. There is a protein called ferroportin. It is the only iron exporter. Without it, you don't export iron. Hepcidin blocks ferroportin. In normals, hepcidin goes up when you don't need iron. It goes down when you do need iron. And it regulates iron utilization. The macrophages, which carry iron because they are iron avid, circulate and create a reservoir. But they really can't carry much more than 500 to 600 milligrams, which is data that I learned from Nancy Andrews, who was the dean of Duke University until last year. And when people are sick, their hepcidin goes up. I didn't say sick with what? Sick with anything. Certainly with inflammatory bowel disease, the hepcidin goes sky high, blocking iron utilization. And to use this oral iron, which makes the vast majority of IBD patients miserable when it really doesn't work, because this inflammatory process really defies minimum common sense. And there are gastroenterologists who think that I need to be sedated. And all you have to do is to talk to patients who get oral iron or have IV iron, and you will see what I'm saying is absolutely true. So there's no in vitro data for this slide, but why does iron get into the macrophage and not IV iron, not oral iron? And the answer is because you're given a lot of IV iron at one point, the macrophages pick it up. When they pick up a lot of iron, it upregulates these proteins called iron regulatory proteins 1 and 2, which actually upregulate the cell's ferroportin, bypassing this hepcidin block. And even though you don't have proof of this with in vitro studies, the huge decrease in erythropoiesis stimulating agents, that's Procrit and Aranesp, to get the time to targets in anemia of chronic kidney disease and chemotherapy-induced anemia, certainly supports what I just told you. Oral iron doesn't do it, IV iron does. Side effects. With oral iron, by the way, you went to school. When I went to school, they told me it was well tolerated. They must be kidding. 70% published data reports significant gastrointestinal perturbation with constipation, metallic taste, nausea, gastric cramping, and thick, green, tenacious stool. And it's especially miserable in pregnant women who are already constipated because of the high progesterone levels, which slow bowel transit, and then the enlarging uterus pressing posteriorly on the rectum. IV iron in 1 to 3% of patients causes a minor infusion reaction, which is pressure in the chest or back, flushing, tickling in the throat, and it goes away in minutes without treatment. Severe hypersensitivity can occur with any IV medication. It is vanishingly rare with IV iron, but just like anybody who gives anything IV, you got to be prepared to deal with it if it happens. It's not unique to IV iron, and I'm not going to teach you about anaphylaxis today. By the way, in almost 80,000 doses, I've never seen it, except with 1 of 2 doses of dexferrum that I gave about 35 years ago. Subsequently, by the way, that drug is gone. Good riddance. In 2009, it was taken off the market. But before that, it was removed from formularies for all the VA hospitals in the United States. The NCCN and the American Society of Nephrology proscribed it by brand. So don't use dexferrum. It's unusual to have something like that happen. Bad drug. All right, this was the study I told you about. It's published in PLOS 1. Tolkien is the first author, and this is whether or not oral iron in prospective studies compared to placebo or IV iron was associated with GI side effects. No is on the left, yes is on the right. And what this really comes down to is that almost 75% of people report significant gastrointestinal perturbation with oral iron, and these numbers are quite significant. So remember what I told you I was going to show you why this is even more onerous? This is high quality new data. Take a look what happens when you raise iron dose and then look at fractional absorption, okay? So when you give 40 milligrams of iron, your absorption is higher than when you give 240 milligrams of iron. And when you give it daily, your absorption goes down because hepcidin goes up. Here's a hepcidin curve with a single oral dose of iron. Then, when you take a look at plasma hepcidin, it goes up 5-fold when you take 1 iron pill. And this is with 80 milligrams or 240 milligrams. And then, So what you're seeing is the change here. The hepcidin increases after a single dose, peaks at 8 hours, elevated at 24, but not 48. So if you take iron every other day or every third day, you get just as much as if you take it every day or twice a day. And here are the absorbed milligrams using radio-labeled iron published in Lancet Hematology from Michael Zimmerman's group in Switzerland just last year. So you have this disgusting medicine who makes the majority of people miserable, and now you have new data to say that you get just as much if you take it every other day or every third day, which may make me have to calm down a little bit about oral iron, because it looks as if this better way to take it is going to have significantly fewer GI side effects, but nowhere near the safety profile of intravenous iron. We're still going to be way ahead. And my point about, oh, and here you see, I knew I skipped the slide, that doses of 100 milligrams have approximately 50% fewer side effects than doses of 200 milligrams. And that's extremely important, as less is more. Remember, this is the commonest malady on earth, and what I just took you through right now with oral iron is the front line standard almost everywhere in the world. You certainly believed that before I started talking today. So now, when I told you about why these drugs are so cool and why you can give a total dose, this is labile-free iron. This is why ferumoxytol got into so much trouble, because they gave so much so fast. But with iron sucrose or Venofer and ferric gluconate or Ferlecit, there's so much labile-free iron that if you give more than a couple of 100 milligrams, you make your patient sick. Not life-threatening sick, miserable sick. Nauseous, swollen, sometimes acute onset of diarrhea, achy. You can't do it. There's a paper in the American Journal of Kidney Disease that says, do not go above 200 for gluconate or 300 for sucrose, which means 4 to 5 visits, 4 to 5 IVs to do what we can in one with monoferric, or in the United States, this is Ferraheme or Injectafer. In Europe, because they have 1,000 milligram vials. And here you are with ferric erythromaltose or monoferric. You can easily give a full dose because it binds the iron so tightly, as opposed to these sugars or salts that bind them weakly. Okay, most important thing. You guys learned IV iron's dangerous. What are you gonna do if you see this 7-month pregnant woman get this 30 seconds after the test dose? And I'm gonna tell you, without talking to me, is you're gonna freak, and you're gonna give her epinephrine and diphenhydramine, and you're gonna turn this absolutely harmless reaction into a clinically significant and hemodynamically significant serious adverse event. Here she is, recovered, okay, all gone, just a few minutes later. And the key is we gave her methylprednisolone and famotidine, which is Pepsid, and gave her the iron that caused this. Okay? This is not an SAE. This is not anaphylaxis. This is a minor infusion reaction, probably complement mediated. Here it is in a man, but it's exactly the same story. Both of these individuals got the, who is moving? Am I doing that? Both of these individuals got the iron that caused the reaction. And in the management of these events, this paper is published in the very prestigious European journal Hematology by Rampton et al. And you can see, and by the way, my slides are available to you, so you can have them, that the treatment of iron reactions that I just showed you, mild and moderate, that I just showed you pictures, is exactly what I told you. Nowhere on these slides do you see Benadryl. Nowhere here do you see epinephrine. It says to consider steroids. I use methylprednisolone. He uses hydrocortisone. Use your favorite steroid. Don't care. Don't give Benadryl. These are not histamine-mediated reactions. We've measured tryptase levels on these patients, and they are normal. Now, here you are, severe life-threatening reaction, but this has nothing to do with iron uniquely. This is any severe hypersensitivity reaction. This is what you're supposed to do. You can live to be 1,000. You're not going to have to do this with IV iron. Well, that's not true. I'm sure it occurs sometimes, but I'm getting to 80,000 doses without one of these reactions now. That's for real, since 1986. 80,000. We do 60 a week in my office. That's 4,000 a year. So it's, it's about 80,000 doses, and I've never seen one. Hope I never do. Sorry, that's my dog, excuse me. So, in a very high quality paper supporting what I said in the Mayo Clinic proceedings, Avni et al. Out of Anat Gaffer-Tvili's group in Israel took a look at over 10,000 patients, okay? And they compared 4,000 to oral iron, 1,300 to no iron, 3,300 to placebo, and I shudder at this, 155 to intramuscular iron. So let's just take an aside for a second. IM iron is painful. It stains the buttock permanently. It's not safer. It requires multiple injections. And it's actually been associated with sarcoma. It shouldn't be given to anyone, anytime, anywhere, for any reason on the planet. Otherwise, I have no opinion about that. Moving on. There was no increased risk of SAEs. 10,000 people, 10,000. No increased risk compared to any comparator, including placebo. No increased risk. There were infusion reactions. But compared to oral iron, the toxicity was enormously lower, enormously. And of the formulations, there was no difference in safety or efficacy. So anyone who tells you one is safer than the other, every one of these drugs have been compared to head. They are equally safe and equally efficacious. Ferric carboxymaltose causes hypophosphatemia in 50% of the people to whom it's prescribed, and no one knows whether that's clinically significant or not. But there was a paper in JAMA on it in February of this year suggesting that there is protracted hypophosphatemia. The verdict is out on that. It's a good drug otherwise. It's easy to give. And in Europe, you can give a gram in 15 minutes. But in the United States, we're stuck with a 750 milligram vial. And you all would pass out if you found out what we pay for drugs. For that 750 milligram vial, my cost is $843. So to give a gram, I have to waste 500 milligrams. It costs me $1,686 to give a gram. Ridiculous. So here you see all the studies that were in the Avni paper, and what you can see is that there is no evidence of an increase in severe hypersensitivity in any of these trials. I can't see the forest plot over here because the pictures are blocking it, but all of the black diamonds are to the right of the unity curve. Okay, IV iron is safe, and it is ridiculous, given the thousands of patients that have been published now, to say that it is not safe. So the best way to do it is prospective randomized controlled studies. So let's see what we have published recently, okay? The highest quality evidence is prospective randomized. And the newest and highest level of evidence comes from a number of robust clinical trials designed and powered to evaluate severe and moderate severe hypersensitivity reactions as the primary endpoint. Safety's first, efficacy second. Iron sucrose, or Venofer, has been the gold standard around the world for decades. In my opinion, the relative safety of this drug has been enormously misrepresented compared to the others. And now I'm going to show you the prospective data. Here we have 3 studies. FERWON, Nephro and IDA compared ferric dirysomaltose to iron sucrose. FERM compared ferromoxetol to ferric carboxymaltose. Phosphare compared ferric dirysomaltose to ferric carboxymaltose. That's Monifer to Injectifer. And Injectifer has been compared to iron sucrose. That was called fine CKD, and it is equally safe. I'm not going to show you that data today because they're all the same. The FERWON study was 2 trials. It included patients with iron deficiency of mixed etiologies and iron deficiency with CKD. And it was powered to look for the risk of serious hypersensitivity reactions, comparing it to iron sucrose. I am the author of this paper along with my colleagues, and it's in the American Journal of Hematology last year. The adjudication was blind. So the people who were deciding on what the adverse events were did not have knowledge of which drug was given, and a secondary outcome was the change in hemoglobin, but everybody knows that IV iron works. And so showing you that it works, it gets boring. Every single study that compares IV iron to either nothing or oral iron shows efficacy and usually marked superiority. So here you have the difference in hypersensitivity. I would call that no difference. Certainly not significant. Here you have change in hemoglobin and ferritin. So I just want you to know that they use this for advertising, because there's no question that when you give the big dose of iron ferric dirysomaltose, can you please not get confused by this? Iron isomaltoside was its first name. That's what it was called when we published this. I have not had to deal with a change in a generic name in the 45 years I've been a doctor, but the generic name changed. So I'm gonna refer to it as isomaltoside for these slides because that's what's on the slides, but that's what dirysomaltose is. Sorry, it's not my fault. You see this? Ferritin goes up faster and TSAT goes up faster. They're the same by week 8 or 9. Doesn't matter. This is the answer. Sucrose times 5 is equal to isomaltoside times 1. Just ask yourself, it's you. What do you want? 5 IVs, 5 visits, or 1? Efficacy is the same, safety is the same. I think the best prospective study was this. This was double blind. And some of you are going to say, well, how come you used a gram of ferromoxetol and 1,500 of carboxymaltose? Tell you the answer to that. FDA mandated it. These are the approved methods of giving it. 2 vials of each. A vial of ferromoxetol is 510. A vial of carboxymaltose is 750. 2,000 patients, double blind. 1-to-1 randomization. I just told you this, 2 doses a week apart. That's the approved method. I almost never give ferromoxetol according to approval because I have 4 insurance companies that let me give 1,020 in a single dose. It's just as good, it's just as safe, it's 1 visit instead of 2. But sucrose is 5 to 7. The primary endpoint was safety. The secondary endpoint was the incidence of moderate to severe hypersensitivity, including anaphylaxis. And I think I have efficacy data here. But if I don't have the efficacy data, just let me tell you, that 1,500 of Injectafer was 0.24 grams better than 1,000 of Ferrahene. And that's not clinically significant. And that's why, and that's at 5 weeks. I don't know what it would have been at 12, but that's why I think more than a gram is not a good idea. The people who make monoferric would like to show that more than a gram is a good idea. So if they want to do that, they should. And then I might change my tune here. But at 5 weeks, there was no difference. So you had a blinded independent adjudication panel. The first author was Atkinson, who was chairman of that panel. He's at Hopkins, a professor of immunology. So what you can see here, that there's no difference in the two, no difference at all. There were no SAEs in the entire study, 2,000 patients. Not one SAE, zero. Either drug. And I don't have the efficacy data, but I just told it to you. Zero difference, zero SAEs, 2,000. Now here, this was just published in JAMA of iron isomaltoside or monoferric compared to FCM or Injectafer. It's called Ferinject in Europe, but that's different brand names. The same drug often has a different brand name. Monoferric is Monofer in Europe. I like Monofer more, but it's too bad. I have no choice. Monoferric for me, monoferric for you. The name in the United States will be monoferric. And it was 2 infusions, FDA mandated, or 1 infusion of monoferric. The first time we actually have approval for a total dose infusion on label. I rarely give iron on label, but this is good for on label. Here you see severe hypersensitivity, no difference, no SAEs, no sequelae, zero. So I've showed you almost 3,000 patients so far, 0 SAEs. Here you can see the risk difference for all the studies. And so when people talk about dextran or non-dextran based compounds, you will know if you ever hear somebody saying that a drug is a non-dextran product, that it's pure malarkey. There's no difference. Some people say that ferumoxytol is dextran based. It's not, but the bottom line is, who cares? And as you can see, that the pooled analysis shows no difference. Time to get rid of the name. So now we're going to go on to bariatric surgery as we get into your field. When we eat iron or take it in a pill, it has to be conjugated in the stomach in the presence of acid to vitamin C, amino acids, and sugars. And if it doesn't happen, it gets converted to ferric hydroxide by the massive alkaline rush in the duodenum that's necessary for digestion. That converts the iron to ferric hydroxide, which is unabsorbable. So after gastric bypass, giving oral iron is futile. It's still frontline therapy. American Bariatric Association says it's frontline. You can quote me on this. Giving oral iron to a patient with a Roux-en-Y is cruel. They have to be iron sufficient to keep up the exercise, to continue to lose weight with this life-changing procedure. They reroute their gut to lose weight, and they need to be iron sufficient for adequate energy. It's ridiculous to give them oral iron. These people were given oral iron. At 5 years, 75% of them were iron deficient, despite oral iron. How can the ABA continue to be so blind to the truth? Oral iron doesn't work in this patient population. Stop giving it. For people who have staplings or sleeves, it works a little, But for Christ's sake, excuse me, it takes a year with oral iron to accomplish what you can with these compounds in 15 minutes in a group of individuals who are going to be overwhelmingly intolerant of it. I think after bariatric surgery, oral iron should be contraindicated, proscribed. Here is a listing of published comparisons. The blue box or the green box is oral, the red boxes are IV. It's not even close. Look at the differences. And this is without any of the gastrointestinal perturbation that you nearly ubiquitously get with oral iron in this group of people who so desperately need to be iron sufficient. So up to this point, did we not have, Usha, what happened to the IBD slides? I hope they're next. Oh, they're not. Well, there are 2 slides in here that I wanted to show you. Actually 3. Let me just tell you what they say. In inflammatory bowel disease, oral iron directly inflames the intestinal epithelium. That's published by Gaethje in the American Journal of Gastroenterology and in Gastroenterology. There are numerous supporting papers in the bibliography in a recent review that I published in Lancet Hematology. But more importantly, Lee et al. Published in Gut in 2017 that when you take oral iron with IBD, there is an incommodious growth of the wrong bacteria, negatively altering the microbiome. You take care of these patients, they're sick. They need to be iron sufficient. You don't need to make them worse with oral iron. There's no role for it in IBD. However, the gastroenterologists say if the IBD is quiescent or mild, that low doses of oral iron may be beneficial. I think the doctors who say that should take the oral iron and give their patients IV iron so that they can get better quickly. Oral iron really has no role in inflammatory bowel disease. It looks as if alternate day iron is the best way to do it, and compared to oral iron, IV iron has fewer side effects and is always effective. Always. You can't give it back. Adherence is 100%. It always works. So now, because this was a nursing group, I brought up the thought of maybe talking about IV iron in pregnancy. I imagine a few of you have been pregnant, and I imagine a bunch of you have had oral iron. And I imagine that the majority of you that have had oral iron when you were pregnant were made miserable by it. And I doubt any of you have had IV iron, although I may be wrong. But most of you should have. Now I'm going to show you why. Guidelines differ. United States Preventative Services Task Force says there's insufficient evidence that routine screening and supplementation for iron deficiency improves maternal or fetal outcomes. I'm going to show you that that statement's flat out ridiculous. The 2008 ACOG practice bulletin says IV iron is recommended in the rare patient who cannot tolerate it. We have a new definition of rare, 70%, or won't take modest doses. And that intravenous iron should only be used in those rare circumstances. It's an utterly ridiculous, antiquated statement, badly in need of revision. But the new 2019 United Kingdom guidelines say that parenteral iron should be considered from the second trimester onwards and during the postpartum period for women who fail to respond or are intolerant of oral iron, and that all risk, high-risk primary, high-risk gravidas, we'll get to high risk in a minute, should be screened for iron deficiency. And I'm going to show you what happens when you screen in not high-risk patients and how utterly ridiculous the United States Preventative Services Task Force publication in Annals of Internal Medicine in 2015 is. They need to rewrite that paper. In Blood in 2017, our top hematology journal, Achebi and Gavili said that IV iron should be given to any oral intolerant woman, to any second trimester gravida with a hemoglobin less than 10.5, all in the third trimester, because oral iron doesn't get to the baby. And wait till I show you these outcomes in a minute in high quality neonatology publications that have been around for years. We have no guidelines for the non-anemic iron deficient pregnant woman, but there's now high quality data that iron deficiency independent of anemia is also associated with negative fetal outcomes. And if any of you have an autistic child, what I'm about to tell you is going to upset you. So be ready. In the non-gravid state, you really don't need more iron than you need in the gravid state, but in the second and third trimester, the numbers go up 6 to 8-fold, and there's no credible expectation that a drug that causes 70% of its people to be significantly constipated and a GI upset is going to be taken when 10% of it is absorbed, and when taking it every day blocks its own absorption, so you have to take it every other day or every third day. How on earth are you going to get this kind of iron into a developing fetus? And the answer is simple. You're not, and I'm going to show you how you're not in a minute. Maternal iron deficiency potentially affects fetal and neonatal and childhood brain growth and development with adverse effects on myelination, neurotransmitters, and brain function. Children who were born to iron deficient mothers demonstrate lower cognitive function and motor development that's measurable up to age 19 years. Gives me goose pimples every time I read this slide. It is unbelievable that this data is ignored by the OBGYN community. It's staggering. It defies common sense. Iron deficiency anemia in pregnancy has been associated with an increase in perinatal outcomes, including preterm birth, low birth weight, and small for gestational age infants. And here are all the publications that show it. And there was just an incredible paper in JAMA Psychiatry, a very high impact journal, that says that anemia at any time in pregnancy is associated with inferior outcomes. There is a reduction in fetal iron status when the maternal ferritin is low, and that when you give supplementation, remember, we don't screen. These women were screened, and they got oral iron, and the babies were screened. We don't screen our babies. They're born, 45% are iron deficient despite maternal oral iron supplementation, and being born iron deficient is associated with negative outcomes. And here they come. This is from the amazing work of Michael Georgetown in pediatric research. He is the chairman of the Department of Neonatology at the University of Minnesota and professor of both OBGYN and pediatrics. And he calls this purple box, and forgive the vernacular, the SOL period. Because after this, giving iron to the baby doesn't change these negative outcomes. So it's not postnatal iron repletion that matters, it's intranatal iron sufficiency that makes a difference, and you can't do it with oral iron. Here you have mothers from that study of 2,400 urban women where the babies were screened at birth and cord ferritins were measured. And irrespective of what happened to the mother, irrespective, the baby's ferritin did not improve. 45% of these babies were iron deficient, and they now have 18-year data on these babies. And the motor and cognitive and behavioral abnormalities are statistically significant. This is shocking because it is time to change our standard. The United Kingdom is moving towards this. In the United States, the American College of Obstetrics and Gynecology guidelines on this topic border on medieval. The Canadian guidelines are not much better. Who's at risk? Now let's just take a look at this population. Iron deficient mothers or those previously treated for iron deficiency. Mothers who are underweight or overweight, or with diabetes, or vegetarians, or multiples, or mothers with IBD, or mothers with HIV, or mothers who smoke, or mothers with a short intrapartum period, or multiples, or mothers with a history of abnormal uterine bleeding. Who's left? Anyone in this room not fall into one of these groups? Why aren't we screening every first trimester gravid? When I show you how ridiculous that is, this is my data, just published in the Journal of Maternal Fetal Medicine. We screened 104 consecutive non-selected iron deficient, non-anemic, consecutive, non-selected first trimester gravidas presenting to their OB saying, hi, I'm pregnant. And we stratified it for gravidity. And 42% of them were iron deficient, all of whom would have been missed. 100% of them would have been missed with current guidelines based on either a low serum ferritin, a low percent saturation of transferrin, or both. And here you have the stratification by gravidity in the next slide, and it didn't make a difference until you got out to gravida 4. Prima gravidas 1, 2, or 3, 42% iron deficient. All who would have been missed based on the United States Preventative Services Task Force guidelines. This is the paper in JAMA Psych. These are the odds of each outcome according to gestational week. Okay? Attention deficit disorders, autism spectrum disorders. This should give you chills. You should go, oh my God, when you look at this. JAMA Psychiatry is a top-notch journal. And for all intents and purposes, the American and the Canadian OBGYN communities ignore this. Here is a prospective study with monopheric in pregnancy. There were no serious adverse events. This was just published in the low-impact journal, Archives of Gynecology and Obstetrics. It was just published. You can see a clear benefit of intravenous iron, but safety again was the outcome, and there were no significant adverse events. 9 of 10 patients had a minor infusion reaction, and that patient was not restarted because the doctor believed the patient had anaphylaxis when they had a minor infusion reaction. Okay? So if it occurred, the midwife stopped the infusion like I told you to do. The symptoms abated. We pre-medicate at that point, and then the infusion was resumed at 50% of its original rate, and all 9 received the desired dose. So this is a quote from the paper, but really paraphrases what I have told you in the past. There seems to be an unjustified fear among healthcare professionals of giving even modern IV formulations to gravidas. Adverse reactions are mistakenly described as anaphylaxis, prompting unnecessary interventions and misleading clinicians about the toxicity profile of IV iron. The confidence and competence provided by regular training, which is basically what I gave you today, should help reduce the anxiety on the part of healthcare professionals. And in fact, it is the anxiety of healthcare professionals giving these drugs that has been shown to increase the risk of serious hypersensitivity. I've already told you about the 70%. Numerous publications support the safety of IV iron in pregnancy. Thousands of women, 0 SAEs. None of the formulations has the highest safety rating, and there are no SAEs reported in any of the studies. So I think the results that I have shown you today and the data support the convenience and safety of a single infusion of iron to treat iron deficiency. We believe as soon as there's oral iron intolerance or in someone who has a disease where it's known to be ineffective or harmful, you go right to IV iron. That's bariatric surgery or IBD. Iron should be, IV iron and not oral iron should be administered in the second trimester if the hemoglobin is less than 10, and to all the babies in the third trimester. If you're going to give oral iron, 1 tablet every other day. I believe oral iron should be prescribed in the third trimester. See how many OBs you can get to agree with that statement. It's perfectly okay to disagree with me on that statement. It would just make you wrong. All pregnant women should be screened for iron deficiency at presentation, and again at the beginning of the third trimester. And all at-risk newborns should be screened for iron deficiency. And in my opinion, all babies should be screened at birth. You got cord blood anyway. You may as well use it and spend a few bucks to get an iron T, IBC, and ferritin. And compared to oral iron, IV iron has fewer side effects. It's nearly always effective. And our data, and that for others, call for large prospective studies of IV versus oral, and they're starting. We're beginning one with Thomas Jefferson University, oral versus IV, and one in India on 5,000 pregnant women, either monoferric, injectifer, or oral iron. It's about to begin. And when I say about to begin, I mean in the next 2 weeks. I think that's my last slide. No. Okay. So in conclusion, oral iron's frontline therapy. It's uncomplicated and tolerated. It's fine. High quality evidence suggests every other day is better. For all of the conditions I've told you, intravenous iron is preferred and should be moved to front line. The preponderance of evidence suggests that the United States Preventative Services Task Force recommendations are in need of revisiting. You have 4 formulations in the United States and Canada that allow you to give it all in a single setting, and it's time that it should be moved forward in our paradigm, and doctors need to learn how to use it because it's a better way to treat the commonest malady you see. I'm sure that's the end.
Thank you, Dr. Auerbach. This was a very informative session. We have a couple of questions in the chat box. So the first one is from Jennifer. With single dose of monoferric, 1,000 milligrams, how much of an increase in ferritin do you anticipate?
Well, if you measure it in the first 4 weeks, it's going to be astronomically high. I can't give you numbers, but ferritin goes up and stays up for 4 to 8 weeks, usually into the 200-ish range. After that, you're much better off using either the reticulocyte hemoglobin content or the percent saturation of transferrin, because remember, ferritin's an acute phase reactant, and the intravenous iron that gets into the bone marrow actually raises the ferritin. But you get the answer. You get a very rapid rise after the first dose. After that, it's less reliable.
So the other comment from Jennifer was that we need to show failure of oral iron prior to getting IV approved. What should we recommend as best oral dose or option? And how long should we put these patients on this before moving to IV iron? Well,
I think 1 ferrous sulfate 325 milligram tablet or a tablet half that size every other day. The absorption of every other day is quantitatively equal to daily or twice daily. Almost nobody can tolerate twice daily. I've never met anyone who could tolerate 3 times daily. My opinion, first sign of intolerance. Why wait? Oral iron causes nausea, gastric cramping, constipation, or diarrhea. If you're pregnant and constipated, it's miserable. So first sign of oral iron intolerance. That's enough. If your regulators require it, say patient took an iron pill, made him sick, that's intolerance.
So
I usually don't go there in pregnancy, but.
Okay, so.
And by the way, do you have to show oral iron intolerance in IBD? Please tell me it's not, that's a Canadian law?
So the other question Irina had was, Irina said it was an excellent presentation.
Thank
How often would you monitor ferritin following an infusion in pregnancy? Is it monthly or is it less
No.
often?
No, in a pregnant woman, unless she's very severe, I usually don't see her again until postpartum because they don't bleed. If it's really severe, I check them again at week 30 to 32. And I always get an iron TIBC. I get a TSAT or a reticulocyte hemoglobin content because the ferritin can be up from the previous IV iron. So I would get used to using the TSAT as your go-to for iron need, not the ferritin.
Okay.
Ferritin goes up in pregnancy, by the way. The majority of the patients that were iron deficient in my study were iron deficient based on TSAT, not ferritin. Ferritin's an acute phase reactant. You know the CRP goes up in pregnancy and the ferritin follows. So if it's severe, check it again around week 30 and then around 2 months postpartum. One should do it. A gram of iron should handle pregnancy. I sometimes give 2, but almost all my gravidas get 1 gram. 5,000 so far, by the way. I've treated 5,000 pregnant women.
So Barbara Curry from Halifax made a comment. We do not have to prove oral iron intolerance. We can just state it and have the IV orders. And she also said the presentation was, it's a great presentation, very informative as well. So I had a question regarding the monoferric. I've used that a few times and then, we monitor patients' symptoms as well as the TSAT and as well as the ferritin. How often can you give monoferric to a patient, IBD patient, whose disease may not be well controlled?
I have given patients with Osler-Weber-Rendu, which is hereditary hemorrhagic telangiectasia, hundreds of doses of IV iron, hundreds, because they need it all the time. They lose it. And by giving them the iron, you give it all the time. You can give an IBD patient IV iron every time they're iron deficient. There's no limit to how much you can give them. As long as the TSAT or ferritin is low, you can give them IV iron.
So the other question is that I had was, our IBD patients are very, very fatigued, and that's a very common symptom. We measure the iron studies, and the ferritin, oftentimes is around the 20s, 30s, 40s, and the GI would say, well, that's fine. You're not iron deficient. Once these patients start having IV iron, the energy gets better and then all of a sudden plummets again. What is our threshold as far as, we sort of telling the physicians she needs more iron or IV iron?
I think that a ferritin of 30 or less, which has a 98% sensitivity and a 92% specificity for absent marrow iron, is a good place to go. But in your patients with IBD, the ferritins can be 300 because of the IBD, and then you have to use the TSAT. And I would use less than 20.
Less than 20, okay.
Yes, and when the reticulocyte hemoglobin content is going to be on every single autoanalyzer and come off right with the CBC, less than 28.
So back to so this is a question I had, back to the pregnant patient. When do we start them? Like they all take prenatal vitamins, and they feel they're getting enough iron. When do we start sort of watching them closely?
In my opinion, the day you find out they're pregnant, that's when they should get an iron TIBC and ferritin. Okay, and if you get it in the first trimester, I think 1 ferrous sulfate every other day is a good idea. They don't need that much iron in the first trimester. I would check them again at week 14. If they're still iron deficient, I'd give them a gram of iron. Then check them again at week 30 to 32. And if at week 14 they're iron sufficient, check them again at week 30 to 32. Because that's when the child needs iron most for normal brain maturation and development. And I showed you the consequences of that. That's not my data. That's published in very high quality neonatology journals.
Okay. So I have a question from Barbara here. She said from Halifax, we do have difficult time accessing IV iron in our infusion clinics when patients' hemoglobin is greater than 90. Can you recommend high quality evidence-based paper that we can discuss in the absence of significant anemia?
Hundreds of them. There are incredible number of patients of data in patients who, in chemotherapy-induced anemia and chronic kidney disease, in congestive heart failure. There's a litany of evidence. Crienbuhl et al. In Blood just a few years ago, non-anemic iron deficient patients showing clear benefits in energy, activity, and quality of life compared to placebo or oral iron. There's a litany of evidence. All you have to do is Google it. I have a review in Lancet Hematology that references most of those papers. It was just published a few weeks ago. There are countless papers in the nephrology literature. There are dozens of papers with IBD showing quality of life, energy, and activity outcomes. 9 is what you have to deal with in Canada. 9 grams.
Yeah.
Well, I use grams per deciliter.
Yeah,
You're using grams per liter. It makes no difference. It's the same number. That's awful. What a medieval recommendation. Country needs to change.
Yeah, that's the issue, is that, you know, the clinics overloaded. There aren't very many private clinics that we can book patients into. You know,
It's going to change.
Isn't there.
You've got champions. You've got Michelle Schulzberg from the University of Toronto, and also Michelle Zeller, Nikki Zeller. I believe she's at McMaster.
Oh, she's at McMaster. She's the hematologist.
Yes, these women are going to bring IV iron forward in Canada. But remember something. Now, the Canadians had dexferrin as their single dose iron. IV iron was a dirty word. You had a horrible formulation for years. And then your only other formulation was Venofer. So if you want to treat a patient, you need to bring them in 5 to 7 times, or you had a drug that was the most dangerous IV iron ever made since 1950. And that's how Canadian doctors became jaded. And that's how the Canadian Medical Association restricted the use of intravenous iron, because of the horrible safety data dexferrin had in Canada.
So Michelle Zeller, I work at McMaster myself, and she has brought the monoferric on the formulary in the hospital. And in fact, during the COVID pandemic, the patients that had Venofer appointments scheduled, they all got some compassionate monoferric isomaltoside.
Nikki's terrific. These two will get new disciples. This sells itself because it is so superior to what has been the standard that the doctors who see it will become interested in. It will generate activity after activity after activity. Because this is just, it's a flat out better way to treat iron deficiency.
So I'm wondering, does anybody else have any more questions for Dr. Auerbach?
Cool, thank you.
It looks like nobody else has questions. This was a fantastic presentation. And I'm happy that you've covered a little bit of pregnancy, because a lot of our IBD patients are young and planning pregnancy, and nurses being advocates for these patients need to know a little bit more about the iron deficiency anemia in pregnancy, especially even with the IBD. So I'm happy that you put that in there. It was a very fantastic presentation, very informative. Here, Robert said, an amazing presentation, very helpful. Those are the comments that I'm hearing in the chat box. So thank you very much.
Pleasure.
We'll probably, have you back again for other sessions. Thank you.
Okay, thank you.
Thank you, everybody, for spending some time here this evening on a summer evening. Bye-bye.